morning, everyone. This is Mo Basine. It's my pleasure to introduce two doctors who are going to be speaking this morning. Dr. Chris Maroules is co-founder and chief operating officer of Innovation Health Service. He's a cardiothoracic radiologist, fellowship trained in cardiac imaging, one of the few fellowship trained cardiothoracic radiologists in the U.S. He's on the board of directors of the Society of Cardiac CT, and his name is well known in many of the guidelines in cardiac CT. He trained at UT Southwestern Medical School in Dallas, where he was part of the Dallas Heart Study, which is well known as a large population-based cardiac research study. And that's where he did his cardiothoracic imaging fellowship in the busiest emergency department in the United States. He, at that time, developed multiple new MRI pulse sequences for evaluating cardiac and lung blood flow. And it's been my pleasure to work with him for almost a decade. Currently, he's serving as the head of cardiothoracic imaging at Portsmouth Naval Hospital. Our second speaker after Chris is going to be Elvis Cami. Elvis is a young cardiologist, cardiothoracic trained imager, and until just recently, a few weeks ago, was the head of cardiothoracic imaging at William Beaumont, another very busy hospital and well known in cardiothoracic imaging. Elvis has probably one of the country's best experience in heart flow technology and FFRct, and he serves as our director of CT strategy. So please welcome both speakers.
Thanks, Mo. I appreciate the introduction. It's really an honor to be here today. Working closely with Dr. Basine and Dr. Cami and several of you on the clinical side is really the most enjoyable part of my career as a cardiovascular radiologist. And I think that the model that we're embracing with Innovation Health Services, of having cardiologists and radiologists partnering together to deliver high quality care and innovation is really setting the standard for how we're going to be practicing in the future. I know from my vantage points, it's really unbelievable to see how much we can achieve when we work together collaboratively, developing strategic and robust pathways for our hospitals, but also improving the lives of our patients. So let me get started here. I don't have any relevant disclosures today. I'd like to start with a 10,000-foot view question, and that is, what is coronary CT angiography? I'm sure most of you have at least some working knowledge of coronary CTA. Many of you have probably ordered one of these exams. So, fundamentally, coronary CT angiography is an imaging modality that's readily available and can accurately and rapidly visualize the heart and the coronary arteries. And with modern CT technology that's available at most of our hospitals, we can produce images with very high spatial detail and low radiation exposure, and then take that data, manipulate it in 3 and 4 dimensions to evaluate for cardiovascular disease. So when we evaluate a coronary data set on our workstation, we have the ability to really provide a comprehensive anatomic evaluation. And that's what sets coronary CTA apart from other non-invasive strategies. We can look at the coronary anatomy to rule out anomalies and establish dominance. We can look at stenosis severity to assess for obstructive disease. And in addition to stenosis, we can look at total atherosclerotic burden throughout the coronary. And so we can identify patients not only with obstructive disease, but with subclinical disease that would still benefit from treatment. And then plaque composition, this is something else we can evaluate, looking at the particular features of plaque that predict poor outcomes and are more likely to develop into culprit lesions. And as my colleague, Dr. Cami, will discuss with you here in a little bit, we now have newer technology that allows us to take this rich anatomic data and from that, non-invasively estimate the fractional flow reserve across a stenosis to assess for lesion-specific ischemia. So, effectively, we've got this comprehensive evaluation of the coronary arteries, both anatomic and now the ability to evaluate for function. So it's really becoming, establishing itself as the ideal non-invasive test to evaluate for coronary disease. With respect to stenosis severity, CTA has very high accuracy compared with invasive cath. And with modern scanners, we could pretty reliably estimate stenosis severity down to about a 5 to 10% range in the majority of patients. It does a particularly good job separating out those patients who have whistle clean coronaries from those who have non-obstructive disease, from those who have obstructive disease and really belong up in the cath lab. We also have good data from this CONFIRM registry. I'm sure many of you are familiar with the CONFIRM registry of almost 24,000 patients. And this really showed us that plaque burden on CTA, not just stenosis, but plaque burden is very prognostic and predicts outcomes incrementally as we progress from normal coronaries to non-obstructive disease all the way to free vessel and left main disease. It also tells us that, among those patients who are scanned and have clean coronaries, there's a very low likelihood of adverse cardiovascular events with a warranty period of at least 7 years, so several years beyond the actual exam. Plaque composition is something else that we can evaluate, and I'm sure many of you are aware this is an area of very active research and tremendous interest. And I think, the point here is what we've come to realize is that not all plaques are equal, and plaques that look different behave differently. And so using CT, we can identify certain high-risk plaque features like a lipid-rich core, positive remodeling, spotty calcification, features that confer a greater risk to the patient completely independent of stenosis severity. Conversely, we can also identify plaques that are low risk and progress very slowly over time, those that are unlikely to rupture and lead to events. And that includes these heavily calcified, high attenuating plaques. So just to recap, what we have with coronary CTA is a very rapid test that can scan the heart in less than about a second at very high spatial resolution, down to the micron level of detail, with comparable radiation to about a diagnostic mammogram. So we've really driven this radiation dose down over the years with modern CT technology. And with that information, we can evaluate for coronary stenosis, plaque morphology, atherosclerosis burden, as well as now lesion-specific ischemia. And now, over the last several years, a number of the large medical societies have started to jump on board and endorse coronary CTA as a frontline test for evaluating stable chest pain and acute chest pain in select patients. And these pathways are collectively being referred to as CT first strategies. So in 2019, the European Society of Cardiology, ESC, updated its guidelines for stable chest pain and gave CT angiography a class 1 recommendation, endorsing this CT first mentality. And what's interesting is that the recommendation for functional imaging has since changed, and now functional imaging is really considered a second line test when the coronary CTA is either non-diagnostic or inconclusive. In 2016, in the United Kingdom, the NICE, the National Institute for Health and Clinical Excellence, updated their chest pain guidelines as well, also giving a very strong endorsement for CT first. with this endorsement, really all patients who come in with typical or atypical angina who are not having a STEMI are recommended directly to undergo coronary CT angiography. And again, functional testing is reserved as a second-order test for patients with non-diagnostic or inconclusive CT exams. And these recommendations were really kind of put forth after a pretty exhaustive economic and outcomes modeling effort that really demonstrated superiority of the CT first strategy over functional imaging or invasive cath as a frontline strategy. Now, for patients presenting to the emergency department with acute chest pain, we also have updated multi-society appropriate use guidelines that were published in JACC back in 2015. And in this document, CTA was considered appropriate as a frontline test for patients who have low to intermediate pretest risk for non-ST elevation, ACS, or an equivocal diagnosis of ACS by virtue of borderline troponins or an early resolution of their ischemic symptoms. You can see that here. And there were lower ratings for echo, cardiac MRI, and resting SPECT. And I should note, I'm sure many of you are aware that updated ACT guidelines for stable chest pain are right around the corner. They're due to hit the press this coming March or April. And it's widely anticipated that these guidelines will also give a Class 1 recommendation for CT first, following suit with what we saw in 2019 with the ESC. In fact, now what we're seeing is that the majority of commercial payers in the U.S. have already done away with their pre-auth for coronary CTA, really in anticipation of these guidelines. Most recently, United Healthcare, which I'm sure you guys are aware. So for the rest of my time, I'd really like to drill down on this value proposition for CT first, both for evaluating stable chest pain and as well as the acute chest pain setting. And there's really 4 key advantages to running a CT first pathway. For one, this exam has unparalleled accuracy and sensitivity for detecting coronary disease. And because of that, when we use it, we see a pretty dramatic increase in appropriate cath referrals and an uptick in PCI CABG. We also see an improvement in patient outcomes, and that's primarily driven by this early revascularization and the identification and management of subclinical disease. And finally, it's an effective frontline test in emergency departments and acute care settings, helping to decompress beds, get patients safely out of the hospital, and ensure appropriate resource utilization. So let's talk briefly about accuracy. Since the early 2000s, there have probably been well over 30 published trials that have looked closely at the accuracy of coronary CTA in various populations with varying prevalences of coronary disease. And these studies consistently show very high accuracy of coronary CTA for detecting obstructive disease, a pooled sensitivity somewhere in the mid to high 90s, and AUCs ranging from 0.9 and up. And when you compare the sensitivity and specificity of CTA to other non-invasive modalities such as stress echo, SPECT, even cardiac MRI, it's pretty clear that CTA is superior. And as I'm about to show you, this added accuracy really directly translates to greater cath lab utilization and improved patient outcomes. One of the reasons why CTA is more accurate than stress testing is because we just miss a lot of disease with our stress testing strategies, particularly non-obstructive disease that still may lead to a large number of adverse cardiovascular events. So if you take, for example, a SPECT MPI exam, there are several scenarios that can lead to a normal perfusion exam. You could have a normal coronary artery, normal coronary arteries, no plaque, no stenosis. That would certainly lead to a normal perfusion scan. However, you could also have diffuse non-obstructive disease without any significant stenosis, or non-obstructive disease with one of these high-risk vulnerable plaques. And I think in both of these scenarios, you still have vulnerable patients and an opportunity to intervene, but all these patients would still fly under the radar on perfusion imaging, and that's irrespective of whether they undergo SPECT or cardiac perfusion, cardiac MRI perfusion, or PET. So consequently, this leads to an increase in appropriate cath and PCI CABG once we implement CT First. We've got a more sensitive test, allowing us to identify more disease and vulnerable disease, and that leads to more invasive angiograms and revascularizations. And this has been documented now in a number of large trials and registries. For example, in the Danish Coronary CTA registry, they looked at over 86,000 patients who had stable chest pain, and patients who underwent coronary CTA were about 60% more likely to undergo PCI CABG compared to those who underwent functional testing, and those differences were significant when compared to stress testing. In another study from 2011 that was published in JAMA, some investigators looked at retrospectively at claims data from 282,000 Medicare patients, and they were interested specifically in the study looking at resource utilization following both coronary CTA and stress testing. And they found that patients who underwent CTA were about twice as likely to undergo invasive cath and over twice as likely to undergo PCI or CABG compared to stress testing. So very similar results from the claims data. If we look at hospital inpatients who were admitted for new onset chest pain, we have data from the PERFECT trial in 2015, published in the Journal of Nuclear Cardiology. And this study compared coronary CTA and stress testing on treatment and resource utilization. It was a little bit smaller of a study, only 411 patients, but it was randomized and controlled. Patients were randomized 1-to-1 to either CTA or stress testing, primarily SPECT. And the results showed, again, a much higher frequency of invasive cath in the CTA arm, 11% versus 2% in the stress testing arm, and more frequent stenting, 6% versus 0%, both of which were significant. And finally, in the ED setting, we have evidence from CT Compare. This was another randomized controlled trial, which took 562 patients with low to intermediate risk acute chest pain and randomized them to either CTA or exercise treadmill testing, and then looked at safety, costs, and downstream testing. And in their study, CTA was associated with a 3.4-fold increase in PCI CABG, but interestingly, significant lower operating costs for the hospital when compared to stress testing. The positive yield of obstructive disease at cath is something else that appears to improve with coronary CTA. And this has been validated now in two very recent landmark studies, PROMISE and Scott Hart. I'm sure everyone's familiar with these trials, both published in the New England Journal. Collectively, the data from these studies shows that the positive yield at cath was over 20% higher with coronary CTA compared to stress testing. And one of the reasons for this higher yield is because the CTA, we can really ensure that patients who end up referred for cath are there for a reason, and that reason is for PCI. We're identifying with confidence of obstructive disease, and we can safely, keep those patients with non-obstructive disease out of the cath lab. So this really helps ensure the majority of cath lab time is dedicated to necessary revascularizations rather than lower RVU diagnostic caths. Another very important added value of CT First is this improvement in patient outcomes. I know this is really what excites us as physicians and imagers. we can now offer patients a diagnostic strategy that directly correlates with lower adverse events. And again, we have a more sensitive test, we're detecting more disease, including subclinical disease, and we're leading patients to earlier appropriate revascularizations and preventive medical treatments. We have 5-year outcomes data from Scott Hart that were recently published in the New England Journal as well. And just to refresh everyone, this is a randomized trial of over 4,000 patients with stable ischemic heart disease. They were randomized either at CT first or stress testing. And the study found there was a pretty significant lower incidence of the primary endpoint, which is a composite of death and non-fatal MI with CT first compared to stress testing. And this was really largely driven by non-fatal MI, not so much death. So what were the driving forces here? For one, within the first year after randomization, 18% more patients in the CT arm underwent revascularization. So there was an earlier detection, and management of obstructive disease. Second, more preventive therapy was also initiated in the CT group after the baseline exam. And that included, higher treatment with both statins and aspirin. So with CT, we're seeing patients with both obstructive and non-obstructive disease are identified earlier and managed more aggressively, leading to this lower downstream risk of non-fatal myocardial infarction over the 5-year follow-up. Looking back at the Danish registry, that very similar trends were observed here. The Danish registry trends are depicted here in the slide in orange bars. Patients who underwent CT first in the Danish study were about 40% more likely to be started on a statin or aspirin, 70% more likely to undergo early revascularization, and had about a 30% lower risk for MI, almost exactly what we saw in Scott Hart. So for the last few minutes of my discussion, let's drill in a little bit more about the benefits of CT first in the emergency department. Under the traditional acute chest pain pathway, patients who come in with low to intermediate risk for ACS typically present, they undergo some baseline testing, and then they're commonly, funneled through an observational status for serial testing and typically undergo some type of provocative stress test at the end of that observation period. Oftentimes, though, the etiology for the patient's chest pain is still unclear, and so it's not uncommon for the patient to then undergo further testing with a CTA PE protocol, or perhaps a CT angiography of the aorta to rule out acute aortic syndrome. And then hopefully, after that, final diagnosis can be rendered with some degree of confidence, and patients who are low risk can be safely discharged home. But all that takes time, sometimes upwards of 24 to 36 hours. Now, in the era of high sensitivity troponins, EDs that have access to this high sensitivity assay, such as, at Norfolk General Hospital, we can really truncate this observation period in many of the low risk patients. But we're still plagued with the same dilemma of not having a clear etiology for the patient's chest pain after that second draw, particularly when the testing is equivocal, which I'm sure all of us can acknowledge is a fairly common scenario. So that's really where CT first can step in and be of tremendous value. If we have the patient undergo a CT first strategy with either coronary CTA or a triple rule out CTA, which I'll discuss here momentarily, this can be very complementary to the high sensitivity troponins. And with it, we can expedite time to diagnosis in less than 3 hours from patient arrival. We can safely exclude coronary disease, and as well as that high-risk plaque that we don't want to miss in the ED setting. And we can also rule out other etiologies for the patient's chest pain. That includes life-threatening etiologies like pulmonary embolism and acute aortic syndrome, but other more common etiologies like COVID pneumonia, which we're seeing a ton of right now. And we have data from several large randomized controlled trials that demonstrate in appropriately selected patients, low to intermediate risk, this strategy is safe. It can reduce the length of stay between 30 and 40%. It eliminates the need for unnecessary diagnostic testing in upwards of 60% of patients. And it can lower operating costs for our hospital systems, 30 to 40%. In 2015, there was this trial called the CATCH trial published in JACC Imaging, which also looked at the long-term clinical impact of this CT first strategy for patients in the emergency department setting. And the study showed there was a significant survival benefit for all the patients who underwent CT first compared to stress testing. And that was both for the composite endpoint, both hard and soft events, but interestingly, also for just when you look solely at hard events, cardiovascular death and MI, there was a statistical advantage of having underwent the CT first strategy in the ED. And so I think this study is very important because it illustrates that not only can we decompress our emergency departments and our telemetry beds with CT first in the ED, but these patients also benefit from the same improvement in outcomes that we're seeing in the stable chest pain populations. Now, one problem that we encounter on coronary CTA, particularly in the ED setting, is that clinically significant non-coronary findings are detected in about 9 to 10% of scans. And again, this includes life-threatening pathology like pulmonary emboli, acute aortic syndrome, but other more common conditions like pneumonia, pericardial effusion, things like that. Because of this, the triple rule-out protocol was created several years ago, published in Radiology, and is being utilized across the country. And it's nice because it has the ability to opacify both the pulmonary arteries and the coronary arteries and aorta in a single imaging session, allowing us to exclude PE, acute aortic syndrome, and coronary disease, all with high confidence. On this slide here, I've got a couple of fly-throughs, and let's see if I can actually get this to play. There we go. So on the left here, you're seeing a fly-through of a conventional coronary CT angiogram. And notice the smaller field of view, and really only the aorta and the coronary arteries are well opacified. This is the right heart here, the right ventricle. The right ventricle and the pulmonary arteries are not opacified with contrast. And compare that with the triple rule-out fly-through. So with the triple rule-out, we extend the field of view craniocaudally to capture the full lungs, and we extend our bolus of contrast so that we enhance both the pulmonary arteries and the aorta and the coronary arteries. So it gives us this expanded diagnostic data set with triple rule-out. Now, there's certainly pros and cons of both these strategies. And with triple rule-out on the pro side, we have good data now demonstrating a comparable diagnostic yield for obstructive disease. It's also associated with lower downstream testing and, as expected, a higher yield for PE and aortic dissection. And on the con side, there are some data suggesting a higher frequency of poor image quality, which is likely associated with the breath hold time. So on some scanner platforms, when you do a triple rule-out, the patient has to hold their breath for a longer period. That's not the case at Sentara Heart Hospital and with modern scanners, but it is on some of the older 64-slide scanners. But radiation dose and contrast volume is always going to be slightly higher with triple rule-out compared to conventional coronary CTA. Really fast, I wanted to briefly highlight the value of CTA and triple rule-out as we continue to try to get a grip on this COVID pandemic. It's important to note that CT can be a very ideal frontline test for these patients who come into the EDs right now, possible close contacts, having symptoms, atypical chest pain, shortness of breath, borderline troponins. If we route these patients through CT first, we can rapidly assess for all those life-threatening pathologies, coronary disease, PE, aortic dissection, but we also can get information in their lungs and identify these very classic pathognomonic features of COVID pneumonia. And if there's any concern that the patient has impaired systolic function, or if echocardiography is not immediately available, it's very easy for us to measure ejection fraction directly on that CT exam. So, this really can provide a strategy for us to maximize bed capacity at hospitals, get patients in and out of the ED faster, and really help limit resource utilization. So with that, I'd like to pass the baton to my colleague, Dr. Elvis Cami, our Director of Strategy and one of our other co-founders of Innovation Health Services. And we will take questions at the end, Dr. Cami and I both. Hopefully he can screen share.
Thank you, Chris. Thank you, Mo, for the introduction. It was a great overview of cardiac CT, Chris. So, thank you, everyone, for the opportunity to speak to you today. So we'll get right to it. This is my disclosure. So when we think about coronary disease, anatomical and functional evaluation, so we have two ways to perform an anatomical evaluation for coronary disease: invasive angiography, and we can assess that functionally by invasive FFR. But when it comes to cardiac CT, up until recently, the only way to do a functional analysis was with the conventional stress test, up until, of course, FFRct became available, and now that can help us evaluate for lesion-specific ischemia. So what exactly is FFRct? So FFRct is obtained from coronary CTA data sets. It is performed through computational fluid dynamics and machine learning, and it uses that CT data to predict the physiological significance of a stenosis. It does not require any additional testing. It does not require any additional radiation or medications beyond what is required for a conventional CT scan. But there is, however, an additional cost. So why is FFRct important? Well, when we look at NCDR data in patients that are referred to the cath lab, the majority of patients that do get referred to the cath lab have non-obstructive disease. And when we look at even patients who have a positive stress test, it's almost like a 50-50 chance that they will have obstructive disease in invasive angiography. And essentially, a stress test it's really inaccurate to act as a gatekeeper to the cath lab. So when we think about patients with true coronary disease in our current strategy, one problem with stress testing is the false negatives that we get. So the dots in red here are supposed to represent the patients with true CAD. And we know that stress testing misses some of these patients. So here's an example of a patient, 52-year-old man who had some risk factors, saw his cardiologist for chest pain, and underwent a stress test, and was able to get a good stress test. 96% of his maximally predicted heart rate got to 10.7 mets. The stress ECG portion was normal, but there was a very small apical defect on the imaging. Now, you could argue that, well, you would be right within the guidelines to treat this patient medically. However, he underwent a CT next, and here are the three coronary arteries. So when we look at, again, through the LAD, there are diffuse disease throughout the LAD. In the proximal segment here, there is a high-risk plaque. In the circumflex, there looks to be a severe stenosis at the ostial segment, and then, again, a lot of disease burden within the RCA as well. So this patient did also have an FFRct, which shows that the FFR is significant in the LAD. One of the diagonal branches is occluded. Another diagonal branch is a positive FFR. The circumflex also has a positive FFRct. And then, interestingly, despite the disease in the mid-RCA here, the FFRct is negative. And this patient essentially had a almost normal stress test. So then he underwent a cath next, which showed the invasive FFR was significant in the LAD as well as in the circumflex, but negative in the RCA. So this patient underwent a 3-vessel bypass, just as the CT and FFRct predicted, with bypasses to the LAD diagonal and OM branch. So another problem with stress testing is that that of the false positives, which we all know about. So and the problem with this is because it leads to unnecessary cath. It's expensive, exposes the patient to higher procedural risks, radiation exposure, and so forth. And as Chris mentioned, when we look at coronary CT, we know that coronary CT has an excellent sensitivity. So we rarely see any false positives with coronary CT. And we know that in patients who are identified as normal, as not having any coronary disease, it has a long warranty period, quote unquote, of about 7 years. But one problem with coronary CT is its specificity. And the specificity of coronary CT does tend to be lower. Here is an example of a right coronary artery. We're seeing calcified plaques throughout the RCA, and it becomes difficult to accurately assess for stenosis severity here because of the calcium. Well, this patient went on to cath, and he did not have any obstructive disease. And this is where FFRct comes in, because FFRct helps to improve the specificity of coronary CT and eliminate some of these false positives. So here the FFRct had correctly predicted that there is no lesion-specific ischemia in this patient. And this is kind of what the platform trial showed. The platform trial randomized patients to either an invasive angiographic approach or a CTA and FFRct first. And what they found was that the rate of non-obstructive CAD in patients who had a cath was 73% in the patients that went directly to cath, whereas the rate of negative cath or non-obstructive disease in the patients who underwent CT and FFRct first was only about 12%, while the rate of revascularization was actually the same in both. And not only this, but in the patients that underwent a CT and FFRct first, there was a 33% lower cost. And this is, of course, assuming for the FFRct cost as well. And then, okay, we can defer some of these unnecessary, perhaps, diagnostic caths, but what about outcome? So when they looked at the 1-year outcome of the patients that the cath was deferred on, the event rate, again, was extremely low, and MACE rate was 0, essentially. Now, what about looking at the accuracy of the test itself? So this is data from the Pacific trial, which compared PET, CT, MPI, and FFRct with invasive angiography and FFR invasively. So these patients, again, these patients underwent all of these tests and then cath. And when we looked at accuracy of a single test, FFRct had the highest accuracy. And as far as combination of testing, well, CT and FFRct again had the highest accuracy as well, again, as compared with invasive FFR. This was a different publication, but still data from the Pacific trial that looked at, again, accuracy of non-invasive testing, and thought was that, well, we know coronary CT has a very, very high sensitivity. Now, what about combining this with a functional test like a SPACT and a PET, and then we'll get an overall higher accuracy? Well, that didn't really work out. The overall accuracy of SPACT and PET was about, combined with CT, was about the same as the individual tests themselves. So it was only that combination with CT and FFRct that led to that really high accuracy. Now, okay, FFRct improves the accuracy of CT, but what about outcomes? So this is data from, on the right, the Danish registry, which showed that essentially patients with FFRct of less than 0.8 had a higher incidence of death, MI, and ACS. And on the left, we see data from the advanced registry, which shows again that patients with FFRct of less than 0.8 have a higher incidence of MACE, and then higher also incidence of revascularization. This is data from patients in the ER that we looked at while I was at Beaumont. So this is patients that presented to the ER with acute chest pain and had a FFRct of above 0.8. And we followed these patients for up to 3 years, and the rate of MI was essentially 0, so 0.4%. The revascularization rate was 7.2%, and the cath rate was 32%. So looking at that a little bit more closely, then we looked at the cath rate and the revascularization rate, and we decided to adjudicate these into either appropriate or inappropriate based on current appropriate use criteria. And after looking at each one, essentially the appropriate use of cath went down to 6.4% from 32%, and the appropriate rate of revascularization was 2.4% after, again, after adjudicating. And when we look at like the CT first pathway, which Chris spoke about, such as in the UK, it's really the addition of FFRct, which makes this possible, again, but increasing the specificity of coronary CT and in reducing some of these false positives. Now, when to consider FFRct? Well, the bulk of the patients that we think should undergo FFRct is the ones with moderate disease, that 50 to 70% stenosis by coronary CT. Now, in addition to that, there are some patients with greater than 70% stenosis by CT that would benefit from FFRct. There are some patients with 25 to 50% stenosis that would benefit from, again, FFRct. And then there are patients with calcified disease or other high-risk plaque features that may benefit from FFRct. Kind of similar when we look at the indication for performing invasive FFR, the range by cath stenosis is 30 to 90%, which is similar to what we're recommending here. And then what about the results of FFRct? Well, essentially, an FFR of greater than, an FFRct of greater than 0.8 is considered, I'm sorry, I apologize because I put this in the wrong box. So obviously this would be an FFR, again, I apologize for this. An FFRct, this should be less than 0.75 in this box. So again, apologies for this. An FFRct of less than 0.75, then those patients should be sent for invasive angiography and PCI. An FFRct, again, this should be greater than 0.8. Apologies for this. These patients can be safely referred for medical therapy. And then we have this gray zone in the middle of 0.75 to 0.8, where correlation with the anatomical findings like plaque characteristics, site of measurement of FFR becomes very important to adjudicate these patients that kind of fall in the gray zone. But taking a step back, when we talk a lot about this FFRct gray zone, we really should understand that FFR is a continuum. We do apply this dichotomous cutoff of 0.8, but there is evidence that is published, like as in here from the advanced registry, which shows that the increased risk of death and MI is higher with decreasing FFRct values. The graph to the right here is data from NXT, which shows that the risk of again MACE decreases with higher values of FFRct, and it's not something that we can apply this cutoff of 0.8, abnormal, but 0.81 is kind of normal. Don't worry about it. And this is kind of that gray zone when we have to integrate the FFRct findings with the other clinical findings. Another thing to think about with FFRct is with interpretation of these abnormal terminal vessels. Here's a patient who has the proximal LAD stenosis. FFRct right after that lesion is negative, but then at the very terminal portion is positive. And we know that FFRct here continues to decline in segments that do not have any disease. So if we're looking at LADs only separated by stenosis severity, and even past that segment with the stenosis, the FFRct continues to decline. And when we interpret FFR as distal to the lesion as opposed to the very terminal vessel, the accuracy of FFRct significantly improves as well. So in summary, the current referral system for invasive angiography is not very effective. We know that layered testing like CT plus PET or CT plus SPECT does not improve the overall accuracy of non-invasive imaging. FFRct does precisely that. It improves the accuracy of coronary CTA and it reduces the number of unnecessary cath with good outcome. It enables the CT first pathway. And with interpretation, it's important to remember that FFR is a continuum and it must be carefully integrated with the anatomy and the other patient clinical findings. Thank you.
Well, I'd like to thank Elvis and Chris, and that was great overview of CT First, of the clinical trial data and all the outcome that are generated, and the guidelines and the novel technology of HeartFlow. Does anyone have any questions for our presenters?
Yeah, go ahead. Dr. Stein has a question.
We struggle a lot with a patient who rolls into the emergency room with a VF or VT arrest of the etiology or a new left bundle branch block and some atypical features. Is a triple rule out reasonable in those patients immediately after hitting the emergency room?
Yeah, I can take that. This is Chris Maroules. I think it's a great question. In fact, that's an area of active research in the University of Washington. They're actually looking at a best strategy to triage those patients. And we are seeing some good data that coronary CTA and particularly the triple rule out protocol can be appropriate in them. I think it's just important to remember, in order to achieve a good quality exam, we still have to beta block these patients or get their heart rates down, at least into the 60s, low 70s, depending upon what type of scanner we have. We've got a good scanner, we can raise the bar a little bit higher. But we still need to have a good quality exam that's really driven by lower heart rates, a cooperative patient. So as long as we can meet that criteria, then I think, yes, it's a very reasonable strategy.
My second question is maybe more for Mo, but the state-of-the-art equipment status in Hampton Roads, where are we?
We have, Ron, we have at Norfolk General, we have 2 cardiac capable scanners. There's the Workhorse, which is in the heart hospital, the dual source Siemens, and there's a cardiac capable scanner in the emergency department in the Norfolk General as well. That's about 10 yards from the ED. And then we have dual source scanners at Virginia Beach General. We have at Princess Anne Hospital. Those are the same scanners that we have at Heart Hospital, very high end, very fast. And so those are the 4 cardiac capable scanners. There's not one at Lee or Careplex or Odyssey. There is a single source scanner at Williamsburg and a cardiac capable scanner at Rockingham. Anybody else have anything?
Great talk. Thank you very much.
Okay.
Great talk.
Thanks, guys.
Thanks, everybody. Have a good day. Be safe.
Thank you. Take care.
Thanks,
Take care,
everybody.
everyone.